fantastic. So wonderful to meet so many of you today. Again, my name is Lissa X. I'm Hernandez. We are fellowship trained pediatric gynecologists. We are so lucky to be involved in collaboratively with your doctors, particularly here at Seattle Children's. And this is a huge plug, Dr. Krieger, and to many other institutions to hire more pediatric gynecologists and OBGYN in general, integrated into your care. And that's what we'd like to talk about today. We work at Seattle Children's primarily and faculty of
Okay, so I'm going to start off with childhood considerations and bladder exstrophy. So gynecologic anomalies are often seen in bladder exstrophy. Anomalies, like pictured in this slide, can range from a completely absent uterus and absent vagina to a complete duplication of both. Your initial surgeries will focus on the reconstruction of the bladder and bladder function, but the vagina and the urethra are just, the vagina is just immediately beneath the urethra and bladder, so it can oftentimes be involved. The vagina serves two purposes. It's a path for menstrual blood to come out, and it also serves for penetrative intercourse. So as the young patient approaches their first period, first and foremost, we want to make sure that they have an adequate outflow for that menstrual blood. Surgeries in the healing process may lead to narrowing or stricture and obstruction of the menstrual outflow. So parents might sometimes have some insight about the child's gynecologic structures from their initial surgeries, but we do oftentimes reevaluate that around the time of puberty, because as the patient is going through puberty, those structures will grow and they'll start to become more obvious. We typically do that with pelvic ultrasounds. We always like to make note about the age of when breast development starts. And once that happens, please try to follow the patients maybe every 6 months or so with an in-clinic exam looking at puberty and also with ultrasounds to see the structures growing. The average age that girls get their first period is around 11 to 12, and we usually expect breast development to happen a couple years before then. Your age of your first cycle also tends to be familial, so we'll also ask about family members and how old they were when they had their first period. If there's any concern about your pelvic structures, either from your first surgeries or from the way things are looking on imaging, we might suggest doing something like an exam under anesthesia and a vaginoscopy, where we put a camera inside of the vagina and take a look around, again, to make sure that there's going to be adequate outflow for that first cycle. In a perfect world, we're following these patients from breast development all the way up to their first cycle. We understand life happens, people get lost to follow up. So kind of during this time frame for parents, big warning signs would be, if your child is already a couple years into breast development, having worsening abdominal pain, maybe on a monthly basis, with or without periods, those would be big warning signs because it would suggest some sort of obstruction.
And I want to make a quick plug that sometimes when we say we examine patients in the office, sometimes everybody's mind goes to scary gynecology appointments, but we're very approachable, and we're not scary, and our exams are very age appropriate. I mean, the notion of a gynecologic exam is very much we need to see and we do what we need to get as many answers as we can, but we also recognize that it's important to meet patients where they're at, meet families where they're at, and so a lot of times it's just looking, or even just joking about what changes are happening to somebody's body. Sometimes as we approach puberty and we're finding that period outflow might not be possible, or even someone who it is possible, we want to talk about how to suppress those periods. And there are times where it's not safe to use some of these methods, and it's times where it's very safe to use certain methods or preferred over other methods. This is a conversation you obviously should be having with your own physician to talk about your particular anatomy, both the anatomy you were born with and the anatomy you had after surgery, but as well as other medical contraindications. For example, patients who are on other medications that might interfere with these, or have history of hypertension related to their renal disease. So there are some medications that might be better or worse. I put this all up there not because you need to read or memorize any of it, but to give you an idea that there are so many options out there. And it's just important to think about which ones might be best for you. Some of the things that are pictured here are like the patch, the pills, the depot shot, an implant in the arm, or an IUD, which is an intrauterine device. And these are not always possible, like I said, to be placed or used in your anatomy, but it might be, and it certainly might be under the care of a specialist who's done so before.
And you might not need anything for your periods either. Okay, so disclosure is a common topic that our patients talk to us about, and you've heard a lot about it today too. Disclosing to teachers about why you need to go to the bathroom, disclosing to friends, disclosing to partners about what's happened in your past. We frequently hear about it as our patients are becoming involved in romantic relationships, or as patients are getting ready to go away for college and kind of prepping, how do I talk to my college roommate about this? What about like my dorm situation? I'm gonna be in a suite versus a private room, that sort of thing. One of our college-age patients told me that disclosure is one of the scariest things that you can do, especially not knowing how people will react. But what she found is that people are generally more loving than you can think. Words of advice that she gave for people about disclosure were talk to people in your community, talk to the people at this conference. What's worked for them? What hasn't worked for them? See if they'll do a little dry run with you about how you would disclose to a partner or a roommate, a friend, about what's happened to you and things around things like that. This is your story. You choose what to tell and when to tell it. And when it comes to romantic relationships, ideally you're with a partner who you're safe, who you feel safe with and who you trust, and who take things at your speed. Working with a clinical psychologist can also be really helpful. And then from a doctor's perspective, we often will write notes for patients advocating for a private bathroom, private room, so that you can do all your medical things safely.
People in the room who wanted to leave the room have already left the room, so I can move on now and talk about some juicy things. So sexual health, and in particular, I think, we talk a lot about intimacy and what that looks like, and we are very lucky to be living in a time, I think, where intimacy means different things to different people, and we are able to have more discourse about it. And I think one really wonderful thing that Dr. Mullerian said this morning is that's true across the board, whether or not you have extrophy. I think adolescence is a period of figuring out what your body looks like, what you want it to look like, how it functions, how you want it to function. And that's a challenge for everybody going through that, and we recognize that. So as adolescent-focused gynecologists, our job is to help empower you to live the life that you want to be able to live and not let your reproductive health needs get in the way of that. So, which kind of brings me to the topic of what vaginas are supposed to do, right? So what are the things that vaginas are supposed to do? Well, one of them in particular is, as I alluded to before, help periods to flow out. And I have met so many young people and adults alike who want to use tampons. They say, I really don't want to use pads anymore. And you know what? Pads have come a long way. Period underwear is an amazing thing that didn't seem to exist. I'd never heard about it before, about 10 years ago. But still, being able to use tampons is really a wonderful option for a lot of young people, and it may require additional procedures into adolescence to be able to accommodate that. And also, for patients who have stenosis, so vaginal stenosis we discussed before, is a narrowing of the vagina either from surgery and scarring or from the anatomy you were born with, that may need to be revised to also allow penetration of any other kind with intimacy. And these are conversations that are ongoing because it's not usually just a one and done surgery. We as surgeons are trained to just see a baby and try to fix it, right? And so a lot of the surgeries that we have been trained to do historically are to restore this kind of textbook anatomy. But the real life implications, as we're learning with our ongoing research, is that 5 years, 10 years, 50 years down the line, patients continue to need revisions. And so one of these aspects is continually reevaluating what kind of surgeries we do in early childhood infancy. And the second part of it is to reevaluate as the patient comes to us with a desire for reevaluation, right? So it's not so much to fix an opening to look a certain way, but to allow it to permit you to do the things that you want to do. And that might be to use tampons, or that might be use penetration. And we also use our staff in a very multidisciplinary model. And I assume many of your centers too. I know our urology colleagues already talked about pelvic floor physical therapy, and we had some questions about that earlier. We are still learning what those best techniques are in terms of pelvic floor physical therapy to accommodate relaxation and strengthening of the pelvic floor muscles. We know that those play a role in comfort with penetration and with intimacy in general, the ability to orgasm and the ability to have a meaningful, intimate relationship that looks different to everybody, just as the concept of being dry is different to everybody. So we're here to say that you should advocate as having access to somebody, a gynecologist ideally, but somebody that you trust to talk to about all these issues who can help be the center point person to help access the care that you want to have. And that starts as early as adolescence. It's not something, because I think, and I'm a parent, so I also recognize there are some things I don't necessarily feel ready to talk about with my kids, but I think they might be ready sooner than I have it with my knowledge. And so I see that as a physician, on the physician side of things, that I want to be accessible for my patients. So I urge you to think about this as well. But we do use mental health people, we use physical therapy people, we use a lot of different kinds of people. And then as we talk about transitioning into the adult world, with our urogynecology colleagues, with adult OBGYNs, and carrying into the next stages of your life.
And the desire to talk about sexual health really varies per patient. I've had some 11-year-olds already talking to me about troubles orgasming. And then I have some 26-year-olds who, don't want to talk about it at all, not ready for anything to go in there. So we always offer it at our appointments. We always offer the conversation, and they either take us up on it or they don't take up on it. Obstetric considerations, as you heard with us talk, this is oftentimes the first thing that parents ask us. Will she be able to have babies? And as you've heard many, many, many times, fertility is not affected by bladder exstrophy. Now, I want to take a step back and just say that in the general population, 1 in 8 women are struggling with fertility. 1 in 4 female physicians are struggling with infertility. So it's around whether or not you have bladder exstrophy, but this should not affect your ability to get pregnant. It is a high-risk pregnancy. Depending on kind of what's going on renally, you might have some high-risk considerations from that standpoint, but from your surgical history, for sure, you're going to be a high-risk patient. So because of that, we definitely recommend preconception counseling. So before you get pregnant, speaking with your physicians involved, your urologist, your nephrologist, your obstetrician, your high-risk obstetrician, about getting pregnant. So that means that if you're having sex, that you are using birth control until you are ready to get pregnant. You'll be followed by that large team with probably having more appointments than a person without bladder exstrophy. A lot of times they'll recommend things like serial renal ultrasounds to make sure that your kidney function is staying healthy. And if you're using a catheterized channel, you might have a hard time with catheters. Classically, they recommended a scheduled C-section with urology present around 37 weeks. These recommendations are always changing to see the time frame, and it is a conversation to be had with your obstetrician about the group delivery. This can vary based off of where you live, what sorts of access you have to 24/7 anesthesia, urology, things like that. And since neither of us practice obstetrics anymore, I never tell a patient that they have to have a C-section or they definitely can have a vaginal delivery, because I'm not going to be the one at 2 o'clock in the morning when they go into labor making that decision for them.
I thought it was really beautiful, Jessica, what you wrote into your bio about your actual delivery and the differences in how your babies are born and all the different processes. So there's often a lot of conversation to be had along the way. So one thing that's also very common in bladder exstrophy patients is pelvic organ prolapse, and there have been many, many wonderful reports on this, with some reports actually saying that it starts as early as the teenage years. And what I have found clinically to be true, although it hasn't really been shown in papers yet, is really sometimes the pelvic organ prolapse that we see in bladder exstrophy is a little bit different than the standard quote-unquote pelvic organ prolapse that we see in people who didn't have exstrophy in their anatomy. So these are some diagrams from OBS, which is the Urogyn Society. These are the measurements that we often take when we are measuring how much and what areas are prolapsed. And then the pictures up top are something called a pessary. There are many, many different styles of pessaries. I just put a couple up here. And those are often non-surgical approaches to manage prolapse. Some of these studies are showing that prolapse is happening as early as age 16, particularly in patients who are symptomatic. That can be really difficult. I mentioned before that there's something called vaginal stenosis, which is frustrating, can be difficult to have penetrative intercourse, it can be difficult to use a tampon, but sometimes it's what's holding up everything from prolapsing. And so we have a difficult conversation, right? Because we fix the stenosis, we allow you to have the penetration of the thing that you need, And then patients develop more prolapse symptoms, and physical therapy may help, but the anatomy is still what it is. So it's always wonderful to think about trying many, many different options. The options that may work may not work for you, may need different options, but it's a conversation that we have this evening. And I think this is one of those situations too where you may feel it differently. Everybody feels it differently. Right? Some people have said to me, you know what, I have a lot of surgeries and I don't feel a lot down there. I can see it or I can feel it when I wipe, but I don't actually feel it. Whereas other patients will say, I feel a bulge down there. I feel like there's a golf ball down there. And when we look, it seems to be kind of hanging low. So there are many options for this. It is not usually an emergency. Nothing is going to fall on the floor, but can be uncomfortable. And it's something, you're not making it up. It's not in your head. It's definitely can be associated with bladder exstrophy. Again, another huge plug of why you should have a gynecologist, or at least somebody who's comfortable taking a look and familiar to taking a look down there. There are surgical corrections that can be used to help elevate some of the pelvic organs back into the pelvis. And of course, when you've had multiple surgeries for exstrophy in the past, that can be a little bit more complicated, particularly if you are in the future anticipating or hoping for pregnancy and carrying a pregnancy, because that is often a case, a time in your life where that prolapse will be worsened. So again, it's very much a case-by-case conversation. We are just beginning to start to do research on this. Again, I think it is a sign of our times that we're able and willing to start talking about some of these things, because it's not like it wasn't happening 50 years ago. I just think the conversation and the dialogue about it. So we appreciate your input on this, and I think it's from these collaborative studies that we're doing with ABC and other organizations that we're really learning these are the issues impacting you, and these are the issues we should be studying further.
So in conclusion, GYN care is ongoing and lifelong. As pediatric gynecologists, we will help provide age-appropriate information about reproductive structures and provide necessary care as indicated. If your center doesn't have a pediatric and adolescent gynecologist, you can always find one close by. Always happy to help.